I'm Dr. Jana Ivanidze, and this is Radiology Imaging Cancer. It's nice to be back. The last podcast episode, published in January this year, was spearheaded by Dr. Adeline Boettcher and focused on animal models in oncologic imaging. If you haven't had a chance to listen to that one yet, please do so. I highly recommend it. COVID-19 was declared a global pandemic on March 11, 2020. And since then, we have all faced unimaginable struggles, personally, professionally, and on a societal level. In fact, it's not over. As I say this, I find myself in the middle of the third school lockdown over the course of a month personally. So if you hear my baby in the background, I'm sorry in advance. But what can we do? In April of last year, Dr. Gary Luker, editor-in-chief at Radiology Imaging Cancer, and Dr. Adeline Boettcher, scientific editor, published an editorial focusing on what they called transitioning to a new normal when it comes to cancer imaging and cancer care more broadly. They revisited the subject last fall and again in January of this year, examining the impact of COVID-19 on clinical care and research in cancer imaging. Today, I'm delighted to welcome them both back to the podcast to discuss how oncologic imaging, both in the clinical setting and in research and academic publishing, unfolded over the past year, what we have learned, and where we in the cancer imaging community should be focusing our efforts going forward. We will then switch gears a bit and talk about COVID vaccines. There has lately been emerging evidence of lymphadenopathy related to recent vaccination, and we will discuss how to interpret staging PET-CT, mammograms, and other imaging studies in that context. Dr. Wendy Tu, trainee editorial board member and an abdominal and interventional fellow at Brigham and Women's Hospital, Harvard Medical School, is author on a manuscript on this topic to be published soon in Imaging Cancer. She will be interviewed by Dr. Michio Taya, also a trainee editorial board member and radiology resident at Weill Cornell Medicine. RSNA is now accepting abstract submissions for RSNA 2021. Submit your abstract and deliver fresh insights about important topics while you shape educational programming at the annual meeting. To get more information and share your work, go to rsna.org/abstracts. Submissions are due no later than 12 noon Central Time on Wednesday, May 5th. Dr. Luker and Dr. Boettcher, thank you so much for joining.
Happy to be here today. Thank you.
Thank you.
Of course, both of you really need no introduction as far as our podcast listeners and readers of our journal are concerned, so I will try to be brief. Dr. Gary Luker is a professor of radiology as well as biomedical engineering, microbiology, and immunology, and associate chair for clinical research at the University of Michigan. On top of his clinical work and his leadership of our journal, he is also a prolific researcher studying functions of cell signaling using molecular imaging. Dr. Adeline Boettcher is the scientific editor for RSNA journals. Prior to joining RSNA in this role in 2019, she completed a PhD at Iowa State University, where she focused on the development of swine biomedical models. She then completed a postdoctoral fellowship at Northwestern University, studying prostate cancer immunotherapy. As I mentioned in the beginning of this episode, Dr. Boettcher recently took over the reins of the podcast for a special feature centered on animal models, her area of expertise. And if you haven't yet had a chance to listen to that, you absolutely should. In April last year, Drs. Luker and Boettcher published an editorial entitled Transitioning to a New Normal After COVID-19, Preparing to Get Back on Track for Cancer Imaging. And if you haven't read it, please do. We will include a link for it in our show notes. Then last fall, they revisited the subject, along with their co-authors from University of Michigan and the NIH, examining how the pandemic has impacted patients with cancer. Today, I'm delighted to welcome them both back to the podcast to discuss how oncologic imaging, both in the clinical setting and in research and academic publishing, unfolded over the past year, what we have learned, and where we in the cancer imaging community should be focusing our efforts going forward. Perhaps we can start by discussing what the impact on clinical cancer imaging was at the beginning of the pandemic in spring 2020. At that time, many imaging practices, as we all know, were forced to go on a temporary shutdown or at least a scale down, particularly outpatient practices, to ensure the safety of their patients and staff. Dr. Luker, could you speak a bit about how institutions implemented these policies and how decisions were made about what has to be prioritized and what has to be postponed?
Sure. I have to say that revisiting the spring of 2020 is somewhat painful for all of us, I'm sure. Yeah. But I think the driving motivation for how clinical cancer imaging responded to the pandemic was really caution in the face of uncertainty. We as a medical community and really world were faced with an entirely new disease, emerging manifestations of the illness that were updated almost daily, it seemed, and uncertainty as to how to best prevent ongoing spread. And I think also in the spring of 2020, institutions perhaps had a naive perspective that if we collectively had marked a lockdown or at least shutdown of some sort for a few months, that we could ride out the pandemic and return to normal very quickly. As we all know, that didn't happen. In terms of cancer imaging, I'll break it down into two aspects of clinical care. One would be follow-up studies for patients who have cancer and we're undergoing surveillance for follow-up, treatment, et cetera. If at all possible, those studies were deferred until a later time. There was a desire to prevent those patients from returning to the hospital. Many of them were highly immunocompromised, a clear risk factor for infection. And then there's also the need to minimize use of personal protective equipment, which was a scarce resource at the time. And institutions wanted to conserve those resources for patients who are actually infected with COVID-19. So most of those patients were deferred, but getting them to return to the fold, so to speak, of cancer imaging was much easier because they had a clear-cut need and clear-cut benefits for returning to imaging. The second aspect relates to screening studies, lung cancer screening, mammography. Those decisions were much easier. Institutions almost universally just deferred those appointments. They tried to say deferred rather than canceled to encourage people to come back. But getting those persons back into the healthcare system has been much harder because of concerns about coming back to a hospital after months of hearing, please don't go to a crowded place, please don't come to the hospital. Now people are hearing the message, please come back for your screening studies, these are important. So getting these people to come back has been much harder. And it's an ongoing challenge that the cancer imaging community faces to re-engage persons in cancer screening. And the impact of that is already starting to show. Initial studies indicate that persons with cancer, particularly breast cancers, lung cancers that would be engaged in screening now are presenting with more advanced disease, larger tumors, and estimates from the National Cancer Institute in the United States suggest that mortalities may increase by 10,000 or more annually because of the stoppage in cancer screening. So institutions had to make the decisions they made based on unclear and uncertain information, but I think we'll continue to see the ramifications of the shutdown or slowdown for years to come.
I think that's a very important point. And I think also as cancer imagers and radiologists who interpret these screening studies in particular, I believe it would be very valuable for us to take a more front and center role in engaging the community and encouraging our patients to come back for these screening studies and advocate for how it can be done in a safe way. So I think this is an important point of engagement and for radiologists to kind of step more into the spotlight. And I encourage
Yes, I agree. And several institutions are actively reaching out through public service announcements, direct calls to patients saying, please come back, this is important. And I think the more that the radiology community and the cancer imaging community reaches out to patients, I think there'll be more success in returning to the pre-pandemic screening strategies.
Absolutely. Let's talk a bit about publishing in the era of COVID-19. So Dr. Boettcher, as someone who oversees the process of manuscripts getting submitted to the RSNA journals, including radiology, imaging cancer, the triage process, and all the editorial work that goes into it, I'd love to hear your perspective on how this process has been impacted by COVID-19, both in terms of the type of publications submitted as well as the volumes of publications submitted.
Yeah. Last year was certainly a whirlwind in the publication world, not only for us, but across, numerous journals. So at our RSNA publishing office, we had, like many other journals, a huge influx of submitted manuscripts throughout the beginning of the pandemic. And most of these initial submissions were impacting our flagship journal, Radiology, as well as Radiology Cardiothoracic Imaging, as many clinics at the beginning stages of the pandemic were interested in the illness, how COVID was impacting the lungs. And, just for context, which seems like ages ago, Radiology received their first COVID manuscript on January 29th, and that was one of the first ones to describe the CT appearance of COVID. And that's something that seems obvious to us now, but everything was very new to us a year ago. Dr. Linda Moy and Dr. David Blumke from Radiology put out an editorial at the end of 2020 that described that they had over 1,400 COVID submissions alone last year. And when a typical year, it was a lot. Within a typical year, they have just 3,000. So, COVID, not only did they have more, but they made up a third of the submissions that they received. And I'm sure that this trend was universal among other academic medical journals, as the real goal across the board was to understand all the different angles of COVID. And again, these research initiatives were taken from a variety of disciplines, so lots of journals were probably impacted in a similar way. And of course, these increased submissions also impacted publication offices too, because of course, with more papers, their workload increased as well. And this ranges from assessing the initial submissions to production, like the article layouts that you see online, to actually getting the papers online. And there are publication staff that handle each of these different processes. So there was more work added there as well. For Radiology, who was receiving a lot of the submissions in the beginning of the pandemic, they had set up daily meetings to specifically discuss COVID manuscripts and implemented an expedited review process to help get these manuscripts out faster. And in the early days of the pandemic, many of the articles were put online within 1 day of acceptance, which is a process that does not occur for typical articles. So shout out to that editorial team for their processes. I know that was a lot of work. As for publications related to COVID and cancer, these topics were not as prevalent in the beginning of the pandemic compared to lung manifestations. And this is for obvious reasons. Many appointments were canceled or postponed. So the cancer and COVID studies were not the main focus of COVID reporting in that phase of the pandemic. But it was about a month or two into the lockdowns that it was clear that these postponements were going to have an impact on this patient population. And many of the first papers that came out related to cancer imaging were guidelines from different groups for handling screening and follow-up imaging appointments safely. And I remember, as we were putting together the editorial in April and the review paper, in the summer, there just wasn't a lot of papers out, but in the summer is when they really started to pick up a little bit more. In the summer is when those research studies began coming out to look at, how COVID was impacting patients with cancer. And then lastly, in terms of how publishing could be impacted in the future months and or years, we might be able to anticipate that there may be a reduction or delay in the number of prospective clinical trials that are published. This will really depend on, where the particular trials are taking place and what outcomes are being assessed. But as these clinical trials were stopped, postponed, or were not able to recruit new participants for long periods of time, there was a substantial loss in the data collected during the last year compared to a normal year. So we'll just have to wait and see and what the longer term impacts on radiology publishing, as well as these new results from clinical trials will be. And as for now, the rush of papers related to COVID has substantially slowed, and most workflows are back to a normal state that they were in pre-pandemic.
Very interesting. I'm curious if you have seen any papers yet, or a substantial number of papers yet, on sort of what's called long COVID and how that pertains to cancer diagnosis, as well as in general the interaction between kind of long-term effects of COVID and cancer.
Yeah, I don't think I've seen many of those at least I don't think for imaging cancer quite yet. Radiology may be starting to get those, but I anticipate, we're at a year now, so I'm sure those studies will start coming out.
Certainly it's becoming more centered now that more and more people live with it, kind of the long-term consequences of having recovered, but perhaps still suffering from some chronic disabilities.
Right.
Yes, so last June, we had a podcast focused on racial disparities in oncologic imaging. And the motivation for the podcast was, of course, the fact that due to a wave of increasing police brutality, there was a reckoning in this society and really worldwide, focusing on how systemic racism permeates every societal structure and every aspect of our lives. And what can we do to take an actively anti-racist stance? And so we talked about racial disparities in oncologic imaging. I spoke with physician scientists actively engaged in their academic work as well as in their daily clinical practice in addressing and dismantling racial disparities in our field, and discussed strategies to combat systemic racism. I certainly learned a lot from that conversation, and if you haven't had a chance to listen to this episode yet, I encourage you to do so. And you can also follow these outstanding colleagues, Drs. Osborne, Miles, Prosper, and Flores, on Twitter to learn more about their work. There is an excellent commentary also on the topic recently published in Radiology, our parent journal, by Drs. Wade, Scott, and Colombo that I highly recommend, and we will be sure to link to it in our show notes. And I thought it would be important to address how COVID-19, a year of living in this pandemic, has impacted pre-existing racial disparities in oncologic imaging and cancer care.
Sure. I mean, clearly this is a topic that could extend well beyond the confines of our podcast, but to focus it on COVID-19 and its impact really on cancer screening, I think is our focus area for right now. And I would just extend it beyond racial disparities to socioeconomic disparities as well, because those in many ways are the leading contributors to the problems that we have in delivering healthcare, particularly in the United States overall. And those problems have been exacerbated greatly by COVID-19. Communities who are already underserved by the healthcare community now faced even a greater challenge in terms of being able to access institutions for cancer screening studies, cancer imaging studies, and even routine care. So institutions really have tried to make targeted approaches to bring these underrepresented groups back into cancer imaging and cancer screening. But it's a long road to do that. Access problems are a major challenge, as well as, in many cases, even trust of the healthcare system because of past injustices and problems. So the socioeconomic disparities, the racial disparities not only impact cancer screening, they've been problems for just outcomes of COVID-19 in general. And that's obviously a broader topic, but it speaks to the challenge of delivering healthcare in a system where, for at least most Americans, the health insurance system is built into employment. And as unemployment rose during COVID-19, many persons lost their healthcare benefits. Yeah. And in that context, without healthcare benefits, the out-of-pocket costs for an elective cancer imaging screening study became prohibitive. And many of those persons have not returned to cancer screening because of lack of healthcare insurance. So that brings up a bigger issue to address, but it speaks to the challenges of re-engaging persons from underrepresented groups in the healthcare system and cancer imaging in particular.
Yes, absolutely. And as we discussed on our previous podcast episode that I mentioned earlier, it's really access, in this case, access to specialized oncologic imaging, both for screening and for diagnostic workup, that is a major root cause of this problem. We know that racial disparities in cancer diagnosis and outcomes correlate with disparities in access to care. And that is what we need to focus our efforts on when addressing racial disparities. And now this problem has been exacerbated by a year of living in the current pandemic.
Yes, and just as a follow-up to that one concrete example, if for persons who have private cars, for example, and receive their healthcare in a suburban setting, it was very easy for practices to say, please drive to our facility, wait in your car until you're called, and then we can bring you in and have your study and then leave. So they didn't have to worry about concerns about mass transit and spacing within waiting rooms, because you could just take advantage of the fact that people could wait in the car. If you're traveling 3 hours to get to your healthcare, or you require busing to get there, those became challenges that couldn't be addressed nearly as easily.
Absolutely. And I think it's important to keep these issues in mind whenever we talk about delivering cancer care, that we have to have on our mind that we want to be inclusive and deliver cancer imaging, high quality cancer imaging and cancer care to all communities. So speaking about all this, it's very difficult to remain optimistic or look for anything positive, given the amount of pain and grief we have all been through as a society and as just human beings on an individual level. But I would love to hear from both of you what you would take away from the past 12 months as far as positive developments that arose from all these struggles we have collectively faced, and that have and will continue to positively impact our professional lives and ultimately contribute to improvements in oncologic imaging and research.
Yeah, so circling back to the last question, obviously as a community, we experienced a lot over the last 12 months. Not only has the pandemic made a substantial impact, but we've also witnessed, the many social injustices, but movements to break down racial disparities as well. Again, not only at the societal level, but in medicine as well. So I, as well as many others, have learned a lot and are continuing to learn about these topics. And with raised awareness in these areas across the board, we can hopefully start moving things in a better direction. And on a different side of things, clearly our work lives have changed over the last year. I'm sure that there are a lot of companies and work groups that could have never imagined having an entire workforce work remotely, and succeeding prior to the pandemic would have worked. But clearly we were forced into this work arrangement. And I think that we have learned that it is indeed possible. In some respects, virtual communication has made it easier to connect with others and talk to them. But on other days, it can feel a little overwhelming. And it'll be interesting to see what the longer term plans are for work arrangements.
Yes, absolutely. In my own personal experience, for example, tumor board has become very different because we all used to come together in a room and sit around a table, but now we're all on Zoom. And in some ways, of course, we all, I'm sure, miss the personal interaction. I know I do. But at the same time, it does make for, in some ways, more inclusive environment. We're able to invite even guest speakers who would normally may or may not have been able to travel for a presentation. So those are definitely some positive things I can think of in terms of collaborating with others, both for clinical patient care and for research. So
yeah, it'll be nice when we can get in person again, because I know a lot of times when we're on Zoom, it's like trying not to talk over somebody, but it's worked, and we've still been able to make progress. So that's the
yes,
important part.
I do look forward to maybe one day having in-person conferences again. I don't know
Right.
when that day will definitively come, but the virtual conferences have all been great, but I'm hopeful that it will not remain this way forever.
I must say I struggled some when you asked me your question to find something optimistic and promising from the past 12 months, but I think some encouraging things we can take away from it, an appreciation for really the challenges of doing what you today are trying to do, Jana, work at home and take care of dependents, whether it's children, whether it's older persons who need care. I think there's an appreciation in the healthcare system more broadly that we need to work to accommodate people's lives, and that there are times when it's not possible to be working at home. The description I've heard, and I think is very apt, is your home and hoping you can get some work done at some point. So I think that that's a realization that we all have to come to. I think in the clinical arena, because of concerns about symptoms, and particularly early on uncertainty as to what symptoms were actually COVID, I think there's a much more realistic expectation for what it means to be sick and stay home versus should I come into work and grind through the day and try to get done, even though I may be infecting other people around me. There's a realization that you can step away. And because many places have implemented read at home workstations, you can still contribute, but you don't have to go into the clinical setting. And I think that that is also an important thing. And even though I definitely miss interpersonal interactions at meetings, I think the hybrid model of virtual and in-person meetings will persist because of a lot of benefits of access, availability, and realistically cost. You don't have to travel to go to a meeting, stay in a hotel, do those things. I realize that for cities that host these conferences, that's a negative if people aren't traveling and so forth. But I think in terms of the goal of the meeting to exchange information about science, clinical care, that having a virtual component makes it much more accessible to people. So I hope out of all this past year, we can become a little bit more humane to each other, a little bit more understanding, and a little bit more willing to encourage others and work collectively.
Yeah, well, thank you very much, Dr. Luker and Dr. Boettcher, for this insightful and inspiring conversation. We will stay on that positive note and turn our attention to what has made us all collectively exhale and has helped us get a sense of seeing light at the end of this very dark tunnel, the rapidly increasing availability of the COVID-19 vaccine, of multiple types of vaccines, in fact. As vaccination programs across the US and globally are ramping up, cancer imagers should expect to see the signs like axillary lymphadenopathy in recently vaccinated patients undergoing cancer screening or staging workup. In the past few months, several illustrative case reports and case series of this clinical scenario have been published, followed by consensus recommendations of expert groups. Dr. Wendy Tu, a fellow at Brigham and Women's Hospital at Harvard Medical School and trainee editorial board member at Radiology Imaging Cancer, has written an insightful editorial on the topic of COVID-19 vaccine-induced axillary lymphadenopathy, which is about to be published. In the next part of the podcast, she will be interviewed by fellow trainee editorial board member, Dr. Michio Taya, radiology resident at Weill Cornell Medicine, my home program in New York City.
Hello, my name is Michio Taya, and I am a second-year diagnostic radiology resident at New York Presbyterian Hospital at Weill Cornell Medicine. I'm on the trainee editorial board here at Radiology Imaging Cancer, and for this segment, I have the privilege of interviewing my fellow trainee editorial board member, Dr. Wendy Tu, who is an abdominal and interventional fellow at Brigham and Women's Hospital at Harvard Medical School. Dr. Tu is the first author of a soon-to-be-published editorial on the topic of COVID-19 vaccine-induced lymphadenopathy. Welcome, Dr. Tu. First, tell us, how common is vaccine-induced axillary lymphadenopathy, and what has been reported in the COVID-19 vaccine trial data so far about the frequency of lymphadenopathy, and how does it compare to other vaccines?
Thank you for the introduction, Michio, and thank you for having me. So we know that post-vaccination axillary lymphadenopathy is probably more common than we thought. In the Moderna vaccine trials, we see that axillary swelling or tenderness in about 12% of patients versus 5% placebo after dose 1. And this increased up to 16% after dose 2 versus 4% in the placebos. The Pfizer trial is not quite as clear since it was not solicited as an adverse event. The lymphadenopathy was mentioned from dose 1 to 30 days after dose 2, and were imbalanced compared to the vaccination group, 64 patients, versus the placebo group, which were only 6 patients. But the true incidence is likely higher given that the axillary swelling was only reported as the unsolicited adverse event. And we know from looking at other vaccines in BCG, influenza, human papillomavirus, axillary lymphadenopathy have been reported, but in much rarer frequencies. And this may be due to the fact that the COVID-19 vaccine has a much higher immunogenic response. One of the few data points we do have is a larger series examining 83 recipients of the influenza vaccine, in which 4 patients had unexpected FTG axillary node accumulation on imaging. So we know to definitely expect more vaccine-associated lymphadenopathy in these newer COVID vaccines compared to our more traditional vaccines.
I see. That's very helpful to help us contextualize sort of what we're observing clinically. And it seems there's been a lot of recent published articles on this dilemma of COVID-19 associated lymphadenopathy, including several from our parent journal Radiology and other imaging specialty journals, including within breast, in nuclear medicine, and cardiothoracic imaging. What's been reported so far in the literature about COVID-19 associated lymphadenopathy?
So there's quite a lot that's been reported so far. This is definitely a hot topic in the imaging literature. As of March, at least 20 articles have been published on this, with at least 18 in imaging journals. We know the first publication was in breast imaging, where vaccine-induced lymphadenopathy was cited as a cause of unilateral axillary lymphadenopathy. As you mentioned, other subspecialties have observed this, including nuclear medicine and cardiothoracics. Most publications had only a single case or a very small number of cases reported, but there is a larger series in breast imaging with 23 women with axillary lymphadenopathy. The majority of these articles reported lymphadenopathy after the 2-dose Pfizer or Moderna vaccines. And more recently, some articles have also cited lymphadenopathy after a single dose of the Oxford AstraZeneca vaccine, which is currently given as 1 dose in the United Kingdom with the 2nd dose planned for delayed administration. The location of the lymphadenopathy is primarily in the axilla, with a few articles reporting cervical lymphadenopathy. We can see these lymphadenopathy on multiple modalities, with the majority of published cases on ultrasound. There's also some demonstrated on PET-CT, MRI, mammography, and CT. So there's been a lot of good data from the literature to help us look at what we should do with this lymphadenopathy in terms of guidelines.
I'm sure there'll be more published to come as well. It seems I see news about this seemingly every day. And as far as, based off this data, what are these society recommendations so far that have been published? And what are some of the common themes and guiding principles for these recommendations?
So the Society of Breast Imaging is the first imaging society to establish guidelines on this, with the Canadian Society of Breast Imaging endorsing the SBI's recommendations. Some key points that they recommended are first, documentation is very important. So having vaccination date, injection site, laterality, and type documented on the patient intake forms or electronic medical record. Also to consider screening exams scheduling. So scheduling screening exams either prior to the first dose of the vaccine or at least 4 to 6 weeks following the 2nd dose to mitigate confusion. And another strategy they could use is to administer vaccine on the side contralateral to the primary cancer and also administering both doses on that same side. For subclinical lymphadenopathy, so this is lymphadenopathy that's only detected on imaging. So now vaccination history is a key piece of data to obtain and to look at when interpreting these studies. In cases of unilateral lymphadenopathy on screening mammography, the initial recommendation of the SBI is to recommend a BI-RADS 0 designation, bring the patient back to assess the ipsilateral breast and have any documentation of vaccination history. And then if this workup is negative and there was history of COVID-19 vaccine on the ipsilateral side in the past month, then to assign a BI-RADS 3 designation with consideration for short-term follow-up in 4 to 12 weeks after the 2nd vaccine dose. And if after all of this, if the lymphadenopathy still persists at follow-up, then to consider a BI-RADS 4 designation and consider biopsy. Now, these recommendations were first announced in January based on kind of very early experience. So these are meant to be very conservative guidelines. And in a recent update in March, the SBI notes that individual practices may wish to establish their own guidelines based on local expertise and also local resources. There's been a different approach suggested in a recent publication in JACR, proposing really just using BI-RADS 2 benign designation after the COVID vaccine vaccination with clinical follow-up. And this is consistent with the ACR BI-RADS recommendations for unilateral lymphadenopathy in the setting of a known inflammatory cause, which in this case would be vaccination. So in comparison with the more conservative SBI recommendations, this pragmatic approach would result in fewer follow-up examinations. But sort of looking at the guiding principles for these recommendations is to understand that a lot of lymphadenopathy after vaccination will be vaccine-associated lymphadenopathy, and to remember to use imaging resources prudently, and to also alleviate patient anxiety with these recommendations.
Certainly, I think it'll be interesting to see, in practice, how often these nodes do get biopsied, since that seems to be the chief potential harm that we're trying to avoid with these recommendations. I'd like to switch gears and sort of ask what your personal experience has been dealing with this dilemma of lymphadenopathy in your own clinical practice. I happen to be rotating through both breast imaging and nuclear medicine at Memorial Sloan Kettering Cancer Center since the start of this year. And for us, this issue arose multiple times a day. Pretty much every day I was on service since January. I dictated quite a few reports where I said, quote, adenopathy in the setting of recent ipsilateral COVID-19 vaccination, probably reactive. And in our case, the vaccination history was integrated nicely into our workflow so that for every examination, whether it was breast MRI or PET CT, information about the dose date, manufacturer, and the laterality popped up on our exam notes every single time. And this was extremely helpful for our interpretation. In your case, has this been talked about in your reading rooms? Have any vaccinated patients been referred to your service or to your colleagues for follow-up imaging or even for biopsy?
For sure, yeah. So this has been definitely a hot topic in the reading room. Our group in Brigham and Women's follows the recently published multidisciplinary guidelines in radiology. So this was done by a group of cancer imagers throughout the country, looking at how to approach lymphadenopathy and when to recommend biopsy. So this is, again, following the principle of interpreting lymphadenopathy in the context of vaccination history, and also looking at the history of primary malignancies and overall metastatic risk. So our immunization information is nicely available in our electronic medical record. It pops up nicely so we can see the recent vaccination when interpreting imaging. If the vaccination is within 6 weeks in the ipsilateral arm in a low-risk patient, so no history of malignancy, or the primary cancer has a low risk of axillary or supraclavicular metastasis, then we report similarly saying likely or most likely due to COVID vaccine-related lymphadenopathy. In potentially high-risk patients, such as ipsilateral breast or head and neck cancer, melanoma or lymphoma, these patients, then we recommend potentially high-risk patient follow-up ultrasound at least 6 weeks after vaccination dose, or to consider biopsy, and that's depending on the referring physician. So again, to use that vaccination history to really determine whether the axillary lymphadenopathy or supraclavicular lymphadenopathy is largely due to context of vaccination, and to use the patient history in the electronic medical record to determine whether biopsy is necessary.
It seems that the 6 weeks seems to be a common time frame. I know at Memorial, that group published sort of their experience recently in radiology. I think they preferred the 6-week follow-up as opposed to 4 weeks, I think, based off their experience seeing persistent enlargement of the nodes even after 4 weeks of follow-up imaging.
For sure, that's a really good point, and something that you point out is that we don't really know exactly the expected duration of post-vaccine lymphadenopathy yet. So it'll be interesting to see what comes out in the literature to assess this, because as you said, the SBI kind of said 4 to 6 weeks in the very early January. And now as more publications come out, that 6 weeks seems to be a more common timing for duration.
Certainly, I think future studies should definitely, it'd be helpful to see sort of what the optimal time frame would be. I think it's a hard question to really answer, but I think that's the question that a lot of people are thinking is, for how long should I be following this up for? What's the appropriate time frame? I think it's a big question. I'd like to end sort of with this final question, which is, what does all of this mean for patients? What is the message I should be telling my friends, my loved ones, about the vaccine and the vaccine as it pertains to imaging, especially those who have breast cancer, head and neck cancer, lymphoma, melanoma, these cancers that have actually no involvement. What should I be telling these patients?
I think widespread education regarding vaccine-induced lymphadenopathy is needed, especially kind of as you point out, this may be a source of anxiety and also maybe mistaken as a sign of malignancy. So we write this editorial kind of in the hopes of educating the public and educating the medical community about this, and for others to spread awareness, to educate other people regarding the side effect, to minimize patient anxiety. And when vaccines are administered, the side effect of axillary lymphadenopathy should be highlighted and also normalized. This is just an immune response initiated by the vaccine, which is a good thing. Patients also should be aware of best times to schedule routine imaging exams. So the SBI has put out a nice infographic for recommendations when to schedule screening exams. And in patients with palpable lymphadenopathy after vaccination, another suggestion may be to proceed with clinical follow-up by the clinician or the patient themselves rather than imaging, and this could result in cost savings to the system. As you mentioned, in these patients with high-risk cancers such as breast, head and neck cancers, lymphoma, and melanoma, to ensure that there is appropriate clinical follow-up for these patients, especially if these lymphadenopathy do not resolve.
I think also too, I've heard anecdotally that, especially from breast imagers, I think they've taken this chance to actually educate their patients and actually encourage vaccination for those who haven't received it. So I think it's also a nice role for us to play to be able to promote vaccination, for the patients that we do see.
For sure, yeah. I mean, the vaccine lymphadenopathy really is just an immune response. So this is a great time for us to educate and promote vaccination.
I couldn't agree more. Thank you so much for speaking with us, Wendy.
Thank you for having me, Michio.
This concludes today's podcast episode for Radiology Imaging Cancer. I hope you enjoyed the conversation with Drs. Luca and Boettcher on how living with COVID-19 for the past year has impacted clinical and basic science research and publishing in the field of oncologic imaging. We also spoke about the impact of COVID-19 on clinical oncologic imaging and cancer care delivery, as well as the role of radiologists in encouraging patients to safely return for screening examinations. We also addressed the impact of COVID-19 on pre-existing racial disparities in oncologic imaging and cancer care more broadly, and how studying and highlighting these issues is now more important than ever before. I also want to thank Drs. Tu and Taya for contributing a very important conversation on imaging findings we have to be aware of in patients who have recently received the COVID-19 vaccine. We will publish links to relevant articles on our website, as always, as well as in our show notes, accessible via your podcast app of choice. We also will have links to everyone's pages and Twitter handles for more information, and we look forward to continuing this discussion with all of you online. Thank you all so much for listening. I hope that you enjoyed this episode and would appreciate your feedback. Please subscribe on Apple Podcasts or wherever you get your podcasts and give us a rating to help more people discover our show. I'm Dr. Jana Ivanidze, and this is Radiology Imaging Cancer. Thank you and see you next month.